This project is about not only sharing the presence of decisions and conversations that have happened about people with severe long-term conditions or terminal illnesses with other services, but about sharing the detail and the narrative and the patient's story with those other services. And what that means is if a patient's had thoughts and has made decisions about how they want their care to be, they have shared that information, very often personal information, with a healthcare professional, and it's that detail that will be shared in this project. So when crises happen, and they do, when people panic, and they do, if the patient ends up in hospital or an A&E, or if they end up phoning 999 and an ambulance crew arrives, the information that's been gathered in a non-frightening moment of their life can be seen immediately. So the healthcare professionals can say, actually, you've had that conversation with the doctor and you didn't want to be admitted. Is that what you would like to happen? And it calms and it de-escalates what can often be a frightening moment. A&E doctors can see that the GP or the district nurse or whoever has had that conversation with that patient. So instead of trying delicately to establish whether resuscitation has been discussed or whether they want admission, they can use that as a prompt, and they've got the details there of exactly, for instance, what I might have heard from my patient about what they'd like to happen. A really good example I've got of that is a gentleman who had quite severe COPD, chronic obstructive pulmonary disease, and that's a respiratory disease, and he was in and out of hospital very frequently. He was never at the point of being ventilated, but was nearly so on his last admission. And he came out of hospital this one time, and I went to see him to see how he was getting on, and he said, I thought I was a goner. I thought that was me. And I said, gosh, that must have been extremely frightening. He said, yes, and I don't want that to happen again. I don't want to go back into hospital, and I don't want to be ventilated. He'd obviously had that thought and gone through that consideration of what was important to him. He wanted to stay at home. So we discussed that we could capture that, and we put in place an emergency healthcare plan, which is one of the decide and right documents. And he became more and more poorly. We kept him at home. Our district nurses started going in regularly, and we put a care plan in place for him to die at home. And because we had alerted everyone to that conversation that had taken place, that's what happened. It also gave permission, if you like, for us to discuss that with his family. So actually they knew, even though it was very distressing, that that's what their husband and dad wanted. He wanted to stay there. And we were able to allow him to die at home, which is a great privilege. But the care that we gave to that patient and his family was fantastic. And that is as a result of having those conversations and sharing those conversations. And if he had gone up to hospital, the hospital would have been able to see that quickly, and perhaps if it had happened, turned him around and got him back home again. And that's what we want out of this project. We want patients' wishes to be seen at their point of time of need, so effective, good quality care can be given to them.